Right, so there's a couple different scenarios where we use hormones for prostate cancer. In the curative setting where there's no evidence it's spread, sometimes we use it with radiation because older studies have showed that for a certain subgroup of people, the combination of chemoradiation is better than radiation. So that's in the localized curative setting. The other setting is maybe you're post-surgery, post-radiation, the PSA is going up, and the hormones are meant to really keep it in check. What the hormones do is lower the male hormone testosterone.
Yep.
So growing, that's important to us for hair and strength and deep voice. It's also what prostate cancer cells feed on. So by eliminating testosterone from the system, that's what helps kill some of the prostate cancers. So that's what keeps the PSA in check for men who it may not be localized anymore. The downside is it's not a curative treatment, so it can keep things in check for a long time, but eventually, and it could be years, the prostate cancer learns to grow survival of the fittest despite the presence of these anti-testosterone medicines. And that's what leads to other types of medicines. The other downside is some of the side effects of the hormones are very undesirable, and the main one is hot flashes. Right, so it can happen all night, it can happen during the day. Some people are affected, some people don't. Some people need medicines for them. But for those who it affects the most, I mean, it's a very morbid side effect. Right, and even more common complaint is the loss of libido or sexual desire, where men don't have the same desire to perform and don't have the same function. And a lot of the times we have them on hormones for years. So it can really be a quality of life impactor, and it's important to have frank discussions, not with the patient, but with the patient's significant other on why this is happening, and make sure they understand that it's our fault, not their fault. So in the setting that you haven't had any treatment yet, if your biopsy results are high enough or your PSA is high enough, they do a CAT scan, bone scan, and just to rule out the presence of disease outside of the prostate. For those groups of men, depending on if you have a high Gleason score, again, you may get hormones. For the men post-treatment, whether it be cryotherapy, surgery, radiation, a rising PSA doesn't always tell us where the cancer is, why it's rising. So again, is it localized to the prostate bed, or the prostate in the case of radiation or cryo? Is it in a lymph node or is it a bone? And a lot of that, if you can't see it on a CAT scan, bone scan, which are the tests we do in that setting, then we rely on the PSA velocity or overall number. So the faster it's going up, the more likely it's somewhere else growing, even though we don't see it. So we wouldn't want to put you through another localized treatment if there's a high likelihood it's somewhere else, because then we're not helping you, but we're causing potentially more side effects. So for example, if you're post-surgery, post-radiation, and localized therapy is not the next appropriate modality, watching your PSA will give us an idea of when to initiate hormones. So, and our studies really give us no great information on the right time to start hormones. So some of it is based on how fast it's going up, whereas others base it on the overall number. Some would want to start it at 10, some start it at 15. Some would say, well, it's going from 2 to 6 to 9, now is the time to start it. And there's really no right answer about when to get on hormones in that setting. And then we've come a long way in terms of systemic therapy options for this scenario. So clinical trials have given us a whole slew of drugs we can use. Generally, hormones is the standard, but when hormones are no longer working, there's a lot of different drugs that come next depending on the features of your prostate cancer. So like a lot of other types of cancers, we've come a long way in terms of targeted therapies and trying to find the next generation of treatments that are effective but don't cause as many side effects. And that's the importance of clinical trials. They do a lot at the Michigan Institute of Urology. They do them at Carmanos, University of Michigan. So that's really at the forefront of the next generation of medicines. And a lot of times when people are out of the standard options, clinical trials are available to try to find, maybe some hope and maybe then the future of cancer care.